Hello, I'm Dr. Dan Haggie. I'd like to welcome everybody to this webinar. I'd also like to thank Dr. Salama and the Dental XP community for giving me the opportunity to speak to everybody about all ceramic dental implants. We're going to try and dispel some of the myths and showcase some clinical results of what is possible with this new implant material. Before I start, I wanted to speak about this quote and talk to you about the way we eat an apple. From an early age, we're all taught that this way of eating an apple is the only way of doing it. We get to enjoy the fruit, and as babies, as children, we learn that this is the most efficient, the best way to do it. But is it really? Eating an apple this way, we always encounter a core. And this, in effect, creates about 30% waste of the apple. We enjoy it, but there is a better way. And that way, we discover, doesn't include a core in the apple. We can chew through and only encounter a handful of seeds. The point I'm getting at is that we've been conditioned to think that certain materials are all we have, and that titanium is the only material that integrates and that can be used to replace teeth predictably. But science has shown differently, and the times are changing, and we have materials that in a way behave very similar to titanium, in many other ways give us results that are sometimes far superior. So my objectives for today are going to be to talk about design characteristics of successful dental implants, talk about zirconia oxide, the indication for use for ceramic implants, and review some clinical cases. I practice in Thornhill, Ontario, which is the city just above Toronto, in a clinic that is focused on implant rehabilitation, and it's moving a lot towards metal-free implant rehabilitation. So, if a patient walks in with a tooth instead of an implant looking like this, all prosthetic principles today are going to lead us to some form of extraction. Whether we're going to extrude the tooth first or extract and socket graft, if this were a tooth, this prosthetically, it wouldn't be restorable. For some reason, the evolution of implant dentistry has taken us to take this artificial root and try to restore it, ignoring the periodontal consequences of this restoration and what we get as periodontal health. And we've been fighting with a lot of complications and a lot of sequelae to this treatment that fills auditoriums and fills lecture halls, and there's a lot of debate about these things. What I'm suggesting is that there might be a better way. There might be something that is more like a tooth, that looks like a tooth, that behaves like a tooth, that integrates into the bone like titanium does, and gives us a much more biomimetic platform to give our patients their desired restorations. So this case is by a doctor in New York, Dr. Shimantov, and this showcases what could be done with these zirconia implants. But the question that everybody asks is, are these things successful? I mean, we can do pretty things with them, but what is the success of these implants? First, we have to really explore what is the measure, what are we measuring when we're talking about success? All the studies, or the early studies with titanium, have all dealt with implant survival. But is that really enough in today's day and age? In 2014, are we just looking at implant survival? Are we looking about hard tissue stability? Are we looking at the soft tissue stability? How happy are the patients? How proud are we of our work? And we discover that although a lot of the studies show us 95, 96, 98% success of titanium implants, very few speak to us about what a more realistic measure of success is. So Jokstad in 93, he wanted to explore design characteristics that are associated with clinical success. And he had 7 clinical outcomes that he explored. osseointegration, mechanical failure of the implant, problems with the implant abutment connection, soft tissue loss, hard tissue loss, aesthetics, and ease of placement. And he correlated these to the design characteristics of the implant. And those design characteristics were numerous, having to do with implant body geometry, to implant material, to the abutment interfaces, and a lot of things. To summarize it, success had to do with the following design characteristics. Implant body geometry, which today is widely accepted. We're using tapered cylinders as an implant design. Implant surface topography is extremely important, and we're using moderately roughened surfaces in all across the board. Implant dimensions are important. We know that a wider implant is going to give us more bone-to-implant contact and therefore give us more stability. We have a lot of research, a lot of discussion about the implant and abutment interface geometry, and that really influences periodontal success of the implant. The abutment material has gotten a lot of discussion. We started with titanium, to gold, to the ceramics, to Emax. What is the ideal material to give us the clinical success we're looking at? And then the last one was implant material. And in Yokstad studies, the implant material really dealt with the type of titanium that was being used. What I'm going to be focusing on is a different class of materials that is going to give us great clinical outcomes. So we're looking at the clinical outcomes with zirconium oxide, and we're going to follow through Yokstad study. So for each clinical outcome, we're going to see why zirconium oxide is a great material. As far as integration goes, we've had research since the early 90s about the integration of zirconia oxide, and there's very little debate about that. Gallard study back in 2007 showed us bone-to-implant contact of a titanium SLA surface compared to a zirconia surface, and very comparable BICs in that study. The small differences mainly had to do with the fact that the titanium in this case was a roughened surface, while the zirconia was a as-sintered surface. And again, there have been numerous studies that showcase the fact that the BICs and the stability is very, very comparable. Romanos summarized the most popular implants on the market and showed us a BIC on average of about 67%, ranging from a low of 59 to a high of about 80%. And the most recent study with the CeraRoot system shows us very comparable BICs at 3 months of about 78%, and removal torque values, which have also been studied to try and see the quality of osseointegration of about 80 Newton centimeters. And these slides are showing us the intimate bone-to-implant contact around that CeraRoot implant, and showcasing the favorable surface of the CeraRoot implant to the cells and to the osteoblasts and the bone matrix. And you can see in this close-up the roughened surface, which promotes the early osseointegration and the early stability. This surface is an acid etched surface in the case of the CeraRoot. There are other surfaces on the market, and we have found in a 5-year success study studying 831 implants, the success rates are equivalent to what we're getting with titanium. So there is science behind these materials. These are no longer considered experimental. There are groups around the world that are using these as almost the exclusive material for tooth replacement. What we have to remember is that we are looking for not only survival, but there are also other parameters that we're looking at. The next clinical outcome that Gallatin was looking at is mechanical failure of the dental implant, and this is really important. A lot of people that I talk to about ceramics, their first comment is that zirconia breaks. So let's talk a little bit about what zirconia is. It's an element on a periodic table. It's very similar to titanium. It sits just below titanium in the periodic table. It is heavier than titanium is. In nature, it's found as batolite, which is zirconia oxide, and also zircon, which is coupled with silicate as a sand. It's obtained through mining, and then through manufacturing process. We can either get a zirconium metal, or we can manufacture the zirconia oxide. So when somebody says that zirconia is in fact a metal, it's not true. Zirconia oxide as a ceramic has the physical properties of a ceramic. It's white in color, it's strong, it's wear resistant, fragile, it's a thermal insulant, it's an electrical insulant, it doesn't oxidize, and it doesn't corrode. As the metal, we have a metallic color, it's malleable, ductile, a thermal conductor, and it's mainly used in nuclear reactors. These are two different forms of the element, much like we have alumina, which is a metal, and then we have the aluminum oxide, which is not. We have titanium, which is the metal, and we have titanium oxide, which is the ceramic, and which is used in composite resins and a lot of other applications. In order to have a material that is stable, the zirconia needs to get stabilized, and that stabilization happens through the addition of yttria. It's a very complicated reductive chlorination process. I am not a chemist, but through a few steps of chlorination, precipitation, and the addition of the yttria, what we get is a yttria tetragonal zirconia, which is a form that is stable at room temperature. Zirconia itself occurs in nature in three solid forms. The first crystal structure is the monoclinic. As it's heated, it changes to a tetragonal structure, and as it's heated further, we get to a cubic structure, which is what the cubic zirconia or the cheap jewelry diamonds are. When the material changes from a pre-sintered to a sintered form, it's changing from the monoclinic to the tetragonal, and that change is very unstable. There's a volume change in it, and once the material cools down, cracks start to form. This is what the yttria is there to stabilize, and once the yttria is in the mix, the material becomes extremely stable at room temperature in its tetragonal state. The other additional benefit of the material is that cracks within the material are arrested by the fact that the tetragonal state compresses and changes to the monoclinical state. And as that crack propagates through the material, internal compressive forces essentially halt the crack from propagating, unlike other ceramics, which make this material extremely strong. It's known in the industry as ceramic steel, with strength of about 900 to 1200 megapascals and extremely narrow range of mechanical failure. Now, the ISO testing for Ceraroot, the ISO 14801, showed static fracture strengths of about 2 to 3,000 newtons and dynamic fracture strength of about 2,000 newtons after 2 million cycles. What does that mean? When we can't compare it to anything, these numbers are really meaningless, and they were meaningless to me too, until we compare it to what we're using today. So this is a study by Bogan and Mish, and the study explored the influence of the hex geometry to the strength of the implant. So if you see, the second line is the 1 millimeter external hex 5 millimeter platform, which is undoubtedly one of the strongest implants on the market. Not widely used anymore as the external hex, but we can take this as a benchmark for strength of titanium. a static failure load strength of about 2,000 newtons, and a fatigue failure load, which is the cyclical loading, of about 625 newtons. If we go down to a more common design today, which is the internal hex, a 1.7 millimeter internal hex, we have a static load failure of about 814 and a fatigue failure of about 400 newtons. Now remember, the difference between ceramics and metal is that a metal is going to bend, whereas a ceramic is going to crack. But when is the ceramic going to crack? The zirconia, if you look at the Serra-Root numbers, static load are about the same as titanium, the 1 millimeter external hex platform, but about 2 to 3 times stronger than the internal hex we're using today. And in a fatigue load, we are much stronger with the zirconia compared to the titanium. So we're talking about a material that is in fact not weaker than titanium, but in fact stronger. The next clinical outcome that Jokstad explored was the mechanical problem to implant abutment connection. I coupled this with the peri-implant mucositis and the marginal bone loss from the mere fact the problems solved with a one-piece zirconia implant don't come from necessarily the zirconia itself, but rather from the one-piece design. This was Hermann's study comparing one-piece versus two-piece titanium implants. And Hermann studied 3 groups of implants within each category. So in the study design, the first group on your far left was a one-piece implant with the rough to smooth junction at bone level. In the second group of implants studied, we had a one-piece implant with the rough to smooth interface below the bone level. And in the third of the one-piece designs, we had a two-piece implant, but the abutment was connected at the time of surgery, with the connection being at bone level, very similar to the one abutment, one time idea. And in the second group, comparing to the two-piece designs, we had the first one with the smooth to rough surface buried under bone, the smooth collar left a little bit supra bony, and then the whole implant basically buried under bone. What we saw at the end of the healing phase was that the implant design that lost the least amount of bone was the one-piece implant with the junction of the smooth to the rough interface being at bone level. Something to note is that the Serra-Root implants are roughened from top to bottom, so that interface between smooth and rough doesn't exist on a Serra-Root implant. The whole implant is a moderately roughened design, which promotes integration, and there's very little bone remodeling during the healing phase because of that. And this study was a landmark, proving that one-piece implants have less bone remodeling compared to all the other designs. Hermann's conclusions, coincidentally, were that there's significantly increased amounts of crestal bone loss around two-piece implants, and the biologic width around one-piece implants was more similar to natural teeth. We've had in the past one-piece titanium implants, but they were not very widely used, mostly because of the prosthetic difficulties with them, as well as the inability of hiding the darker color of the metal as it projected through the tissues. Dental implant designs have looked for ways to minimize the bone loss, and we've had every manufacturer out there trying to solve this ongoing problem with design modifications, with a lot of hype, with some limited success. And what we're finding with the one-piece design is that we don't have the bone loss that we have with the two-piece titanium. A quick case with showcasing the one-piece Serra-Root. This is what the case looks like a day of surgery. This was placed permucosally without an incision. And this is the case at a 7-year follow-up, and this is the only prosthetic connection that exists. There are no screws that can loosen. There is no subgingival connection of components. In this case, the margin is like a CEJ of a tooth. The white part, which is the implant, is like the root. You have recession on natural teeth as well. And this gives us a gingiva that is as healthy as the gingiva is around natural teeth. This showcases the one-piece body without any connections, allowing sort of as natural aesthetics and natural prosthetics as we can have. As with every implant, we have to be careful with hygiene. Periodontal issues occur around these implants as well, just like they do around teeth. This is not a panacea or a solution to everything. So I must stress, because I get this all the time, it's not resistant to plaque. It still accumulates plaque like a tooth would, and oral hygiene still is paramount, even with a material like zirconia. The last two clinical outcomes, aesthetics and ease of placements, are best presented as we get into some clinical cases, and we're going to start with the first one, failing left central incisor, fractured endodontically treated tooth. We perform an atraumatic extraction. We can see the vertical fracture on this tooth. We have the buccal plate is intact. We can see the tooth in the socket that retained it. We use a clear Essex appliance as our surgical guide, and we drill through the incisal edge to get the correct angulation. This is the first drill. Following that angulation, created our osteotomy. The last drill is the countersink, which gives us the built-in emergence profile. So we don't use the restoration to give us the emergence profile through the gum, but we're using the implant body for that. This is the implant body, the CeraRoot number 21, being inserted into the osteotomy and then torqued into place with a ceramic driver. This is the final position, and what we're looking at is not an osseous position of the implant, but now we're working at gum level. So we're placing our restorative margin about 1 millimeter to 0.5 millimeter, maybe subgingivally, or wherever we want to restore the crown. We could leave it at gum level, we can leave it supragingival. It's a prosthetic decision at this point. We're showing enough clearance for the occlusion and a nice placement of the implant. The gap is grafted and everything is sutured together. The PA showing nice implant position. And as a provisional, in this case we didn't load the implant, but we used the Essex appliance with a composite veneer, allowing for undisturbed healing. This is what the case looks like at 15 days. Soft tissue is migrating down and creeping onto the implant. 3 months, we have nice soft tissue maturation, and we have stability of that implant. We're ready to restore. The soft tissue is removed from the palatal with either an electric knife or a laser, and an impression is taken. In this case, we used CeraCrown component to pick up the position of the implant and impression material, and the final crown is delivered. And we can see that we maintained the soft tissue level and barely any remodeling. And looking at the case before and after, we've had very, very little soft tissue changes. So what is ideal tooth replacement? Ideal tooth replacement for me is something that gives me predictable integration, something that gives me minimal mechanical problems, fractures, screw loosenings, and other problems that sometimes we get with two-piece titanium. We want something that is easy to both place the implant and restore it without having to go through a toolkit of components and angulation abutments and those sorts of things. We want something that's going to give us simple, long-lasting aesthetics. We want something that's going to maintain the tissues around the implant, so minimize the amount of marginal bone loss and minimize the peri-implantitis issues that we run into with two-piece designs. What systems are out there on the market? I focus my presentation on CeraRoot because this is the only system that is Health Canada approved, and it's the only system that I have available in Canada. It also is the only system that is tooth specific and gives you the ability to replace a tooth. It's different than our concept of what titanium is, and we're going to go over that in a second when I review the system itself. Other systems that are on the market are the Z system, which comes in a one or even today in a two-piece design. The other systems, like I said, are not Health Canada approved in the chart. The other ones, Dental Point, BraidDent, Eterion, are all again one or two-piece systems that are, as far as I know, not available in North America. The interesting part about this chart is that Nobel has had an implant, a zirconia implant, FDA approved since 2007 that never hit the market. And Straumann is coming out with their ceramic implant monobody, so a one-piece zirconia implant in the fourth quarter of this year. And what we're going to be seeing is that a lot of the titanium manufacturers are going to start introducing zirconia implants because we're reaching a point where these implants have been in use for 10, 12, 15 years. A lot of the initial problems with surfaces, with protocols, with surgical designs have been sorted out, and we're getting success rates that are equivalent to what titanium is and better. And you're going to find that in the next few years, a lot of these implants are going to find their ways to the market. As far as the CeraRoot system, we have a selection of 5 implants. And like I mentioned, this implant system is unique with the fact that it is not diameter based. So we're not looking at, if we have a ridge that is 7 millimeters, we can fit an implant that is 4 millimeters or 4.2 millimeters. That's the one we're going to choose. If we have a ridge that is 5 millimeters, we're going to opt for a 3 millimeter implant. This is not our decision tree in this with this implant. What our decision tree is based on is what tooth are we replacing. So a CeraRoot 1-2 is used to replace a lateral incisor or a lower incisor. A CeraRoot 21 is used to replace a central incisor or canine. A CeraRoot 11 is there to replace a larger central incisor or a larger canine. CeraRoot 14 is a bicuspid replacement, and it is an oval emergence profile. We'll go over that. And a CeraRoot 16 is a molar. And what this system stresses is the fact that we are not replacing a molar with a lateral incisor implant. This is very important to note because it is the reason too that this system has virtually no fractures of the zirconia. Like any ceramic, we need some bulk of zirconia. The more bulk we have of material, the stronger we are. The ISO testing was performed on a CeraRoot 21. You can imagine what the strength of that molar is once it's inserted into the site. Extremely strong material if used correctly. So again, the implant is made completely of zirconium oxide. It's an acid-etched surface, the ice surface, and each implant has a tooth-like emergence profile. A little bit more detail about each implant. The CeraRoot 12 comes in 3 different lengths. It's the only implant that has a non-tapered body. It's a 4.1 millimeter body at the apex, and it's 4.1 at the most coronal portion, with the abutment being 3 millimeters in length. Then we have the CERAROOT 21, which is 4.1 at the apex, 4.8 at the most coronal thread, and then it's a 6 millimeter platform, and it looks like a central incisor preparation with a 5 millimeter abutment length. Then we have the CERAROOT 11, which is in my hands the least used implant. Not many indications for this, but great to have on hand. 4.8 millimeters at the apex, 6 millimeters at the most coronal thread, and a 6.5 millimeter platform. And then we have the CERAROOT 14, which is a beautiful, beautiful implant. 3.5 at the apex, 4.8 at the coronal thread, and the emergence profile, or the restorative platform, is oval, 5 millimeters wide and 7 millimeters long. This particular implant is actually tapped or press fit into place, and it's the go-to implant for a lot of what I do with these, especially for bicuspids, cuspids, and larger rehabilitations. Finally, we have the CERAROOT 16, 4.8 at the apex, 6.5 at the most coronal thread, and an 8 millimeter coronal platform, and the abutment height is 3 millimeters. And again, it's there to replace an upper or lower molar with incredible success and aesthetics. The surgical kit is quite simple. The company offers two types of drills: the steel drills, and then we have a set of the ceramic drills. I favor the ceramic drills for the fact that they're much sharper and don't wear out as much as the steel does. And a lot of the patients who come in that don't want any metal contacting them, it's nice to have the ceramic drills. We have the torque wrench, we have the tools, the countersinks, everything is nicely laid out. At this point, we're going to go through some cases, and we're going to showcase each one of the other implants in use. You're going to see how beautiful the soft tissues are. So this first case is a lower bicuspid, restored with a CERAROOT 14. This is after 3 months of healing, and we can see the health of the soft tissue. This is what this implant is for me, is unbelievably healthy soft tissues that we're barely able to probe them. If we are, they probe like natural teeth. The restoration in my hands of these cases happens with an iTero scanner, and we can see the positioning of the implant on these virtual models. And this, to an untrained eye, would look like I'm really good at preparing teeth. Plenty of intraocclusal space. This is an ideal case for this ceramic implant. And this is the final result with an Emax crown cemented on top. We can see a little bit of the halo of the white zirconia. And this is in contrast to what would have happened had we used a one-piece titanium. In this case, our patients ask us to bleach the roots of the other teeth the same way that we bleached that, because we have a white root. With a one-piece titanium, we could never achieve this. We would have a grayish look to the gum that would not be acceptable to our patients. Our next case is another central incisor. And in this case, we were lucky on the start that we had a gingival level that was much lower than the adjacent tooth. This case is one that I'm going to showcase what happens when a case is somewhat mishandled, and we're going to go through and learn from our mistakes. So again, an endodontically failed tooth. We're going to atraumatically extract this root, and we can see that vertical fracture. We have a facial dehiscence, so we have a compromised buccal plate. The osteotomy is performed, very carefully, and in this case we chose a CeraRoot 11. This, if you remember, it's replacing a larger central incisor, and in this case perhaps the wrong implant to use. Good judgment comes from experience, and experience comes from bad judgment. We learn from these types of cases, and this is why I wanted to showcase not only the great successes, but also some of the things that haven't worked out very well, so that we can all learn from these. This is what the implant looked like. It really pushed out of the osteotomy into the buccal. The bone was relatively soft, and I thought that under prepping would allow me to get a little bit better stability. But this is where we ended up. We ended up with the implant far facial, the implant being too large, and having a very large facial defect. We proceeded to graft this defect with some allograft, with some autogenous bone and a membrane, and we sutured. And we can clearly see that our position is a far facial, where we want to ideally be. This is what it looks like at 2 weeks of healing, and at 5 months with temporization. So at 5 months we're actually looking pretty good. Our gingiva is at a nice level. We think we got lucky. Final restoration, obviously, we had to prep the margin, which is something that we don't do very often with these implants, because we try to ideally place them, but sometimes we need to, and that is not a problem with these implants. We can prep the margin, we can prep the abutment, although we want to minimize the amount of preparation, just because just like a tooth, you want to minimize the amount of tooth that you're reducing. You think about these implants the same way. You want to minimize the amount of reduction to the zirconia, but at the same time you want to perfect your surgical skills, so you have to place it as ideally as possible. So our margin gets prepped here, and this is what the case looks like at 2 years. We've lost some of the facial tissue, we've had some recession, but you can see how beautiful the tissue surrounding the implant is, and the health of the tissue. Had we used the more appropriate implant, could a result been better? I think so. I think this was a surgical bad decision that was made, but again, we learned from this. And what I'm realizing from these mistakes is that had this mistake been done with titanium, this would have been a real problem. I mean, this was accepted by the patient. He didn't object to those teeth being a little bit off. If I needed to correct this, we could probably do a little bit of a gingivectomy on the adjacent tooth. But this is acceptable. With titanium having done the same thing, I don't think we would have been this lucky. So this is what we get from this, is that we never regret. If it's good, if the results are great, we take pictures and we're proud of them. But if it's a bad result, we got to learn from it and move on. If we need to correct these mistakes, we can correct them. But with certain materials, what I'm finding is that our ability to not run into aesthetic problems is there's much more forgiveness with these materials. And this is the final PA before final restoration. This is another case. This one is a missing lateral incisor, tooth number 22. It's been missing for about 6 years. This lady's been walking around with a flipper. Bone volume was good. When the tooth was extracted, it was grafted, and you can see a little bit of the outline of the graft material. There seemed to be enough facial volume of bone, just a soft tissue deficiency here. We made a papilla-sparing incision, started our osteotomy, and inserted a CeraRoot 12 into the site. This is everything sutured with the implant in place, and this is what the implant looks like in the bone. And for this case, we immediately temporized with some acrylic. 3 months after the surgery, everything looks nice and healed. The margin is almost completely covered by soft tissue. And we can see the preoperative radiograph going to the post-placement. And then this is what we looked like at 3 months. And you can see that there is very, very little, if any, bone remodeling around the implant. Again, I restore everything with an iTero. So this is our iTero scan. You can see the nice positioning of the implant, marking of the margins. And this is what the case looked like after 1 year. There's still a little bit of residual scarring on the soft tissue, which with time is gonna resolve. And we can see the beautiful result we have with the soft tissue. And again, there was no soft tissue modeling. We didn't use a whole lot of temporaries to do this. We just allowed everything to heal around that zirconia and placed the crown. This is a very simple case to restore, and we can see how, if we compare the right and left side, we have very nice soft tissues. We have very nice ceramics that were done for the patients, but the most important part is that we have an aesthetic outcome that was extremely simple and extremely predictable in this patient. And this is what we looked like before. The next case is showcasing a molar. Again, an endodontic failure. Implant is placed. This one was placed immediately after the extraction. This is the radiograph of everything healed. Soft tissues, again, look remarkably healthy. They overgrow the restorative platform. We use a soft tissue laser to expose a little bit of the platform and create the final restoration. And this final restoration was zirconia, pre-tau zirconia crown that was cemented on that zirconia implant. And again, you can see the beautiful soft tissue and the beautiful emergence profile. Let's look at some cases. We've looked at a lot of single tooth cases. We're going to look now at some cases of a little bit more complexity, so some multiple teeth. The first case is some perio-involved lower incisors that were deemed to be extracted. Teeth were extracted. We utilized, rather than using the lateral incisors, we used a CeraRoot 14, which in the case of bridges sometimes is much easier to handle a bridge with a shorter abutment, which this has, and a lot of strength because of the width of that abutment. So we used 2 CeraRoot 14s to replace these 4 lower incisors. This is what things look like healed, and that's where we took a gasp of air because our positioning was not ideal. Our implants were a little bit too far towards the midline, and we had to make decisions as to how we're going to restore this. I utilize an application on the iPad called DSD, Smile Designer Pro. And using Smile Designer Pro, we were able to show the patient something that I thought would be more aesthetic, more functionally aesthetic, able to clean this better with 3 teeth as opposed to putting 4 teeth on it. Of course, they didn't accept the 3 teeth solution, so we ended up putting 4 teeth. And I think that the ceramics did a very nice job, and we're going to see how this holds up with the hygiene issue that's going to come up. This is maintainable, but in a perio patient, this might be a little bit higher risk. But again, a very nice looking result when we compare the before and the after. The next case is again failed crown and bridge for this lady. We have 4 crowns, anterior crowns, that show endodontic failure of the restoration. All 4 teeth were removed, and 2 Sera-Root 21s were placed in the central incisor position, and there was a socket seal on the laterals, and this was allowed to heal with a prosthetic rehabilitation of a 4-unit bridge with 2 cantilevers. The day after surgery, everything is progressing really nicely, and this healing state is going to show you the beautiful healing that occurs around the zirconium. The temporization for this case was again an Essex appliance with the acrylic on the teeth. It would have been possible to immediately temporize these teeth as well. It's a clinical decision. If we have enough stability with the implants, much like with titanium, we can choose an immediate temporization without much more risk to the case. At 20 days, our soft tissues around the implants somewhat look nicer than they do around just the extraction sockets. And this is a close-up of that healing. This is at 2.5 months. Again, the sockets don't seem to heal as well as the tissue around the implants does. The angulation issues with these is something that I get a lot of feedback on. As a one-piece implant, a lot of people are worried about the angulation of the reconstruction. I can tell you that if there was a tooth there before, you can put a one-piece implant and there will be very, very little issues with the restoration. These abutments are preppable, so if you need to prep them, you can prep them much like a tooth. But what we're aiming at is replacing teeth. And this is why I say that if there was a tooth there before, you'll be able to place an implant. If the tooth has been missing for 25 years and there is no bone, and you would be able to place a very thin or very narrow titanium implant on an off angle and use a corrective abutment, this is not possible with these implants. But in today's day and age, in 2014, what we're all aiming for is to idealize our sites first and then place the implant. So if you have a case where angulation would be needed, my bet is that if the site was augmented, we could place an implant without an angulated abutment, and that should be our aim. Our goal should be to rebuild the bone and place an implant in the most ideal position. And if we're able to do that, then the zirconia implant, the one piece, is not a problem to place. But if we're unable to, or we have some restrictions or contraindications for grafting on the patient, this is not the implant to use. 5.5 months post-surgery, and this is our temporization. We're trying to build some ovate pontics for the lateral incisors. This is with 4 months with provisionals. The preparation of the canines for some veneers, and then the final ceramics on this case. 1 year post-op radiograph shows beautiful bone levels, and you can see the intra-implant bone level, that spike of bone that is maintained by the emergence profile of the implant. That is not going to disappear. Bone like that around titanium implants is virtually impossible to maintain because of the prosthetic connection. And again, close-up PA of the situation, and this is a final look at where we started and where we ended up with the implants fully healed, nice ovate pontics, and final reconstruction. The last case that I want to review is a full arch, and in this case we have obvious periodontal issues, obvious issues with decay, a very unhealthy mouth. and in this case, suspected metal allergies as well. This case was rehabilitated using 6 zirconia implants, and again, the CeraRoot 14 was utilized in this case. The first question that comes to everybody's mind is, why can I see the implants? If you remember, this is a severe perio patient. Any periodontal literature is going to show you that supragingival margin in a periodontal patient is the preferred margin design because of the ease of keeping this clean. And in this case, comparing the aesthetics from before to the aesthetics after, the patient had no issue with maintaining these margins. If I were the patient, this is the way I would prefer, although if there is a desire to prepare these abutments, one can prepare them to be at gum level and create a more aesthetic result. But I think that going from here to here is a huge enough boost that may be unnecessary, and to safeguard long-term longevity, I don't think there is a problem in having these margins staying supragingival. And again, this is a radiograph of the case with the upper teeth having been removed and 6 implants supporting 2 6-unit bridges each, with the cantilever in the posterior that's not loaded. So full arch rehabilitation is possible with these implants in select cases where we have ideal bone topography to be able to provide a tooth replacement. So I would like to summarize what we went over today. Zirconia oxide dental implants are an ideal tooth treatment replacement option, and in the coming years we're going to see that this is becoming slowly the most ideal and the most predictable form of tooth replacement. The material is highly biomimetic, exhibits good fixation, osseointegration, and high levels of long-term stability and aesthetics. There are 5, 10, 12-year studies coming out that show comparable survival of these implants, comparable long-term maintenance of the restorations and of the implants in the mouth. The implants can be used for single or multiple tooth replacement. Case selection is important, and case selection is important with everything that we do on a daily basis. There are cases where I wouldn't consider using a ceramic implant, and there are cases where today I don't reach for my titanium anymore. I just reach for the ceramic. So one has to learn which cases are which, and minimize the risk with either material. Implant, which is the one that I use, it simplifies restorative phase, and I find that it virtually eliminates the prosthetic complications that we see with a 2-piece titanium implants, whether it's things like peri-implantitis or screw loosening. This material acts, once it's integrated, like a tooth, and it restores like a tooth very simply and extremely aesthetically. I would like to thank Dental XP, and I would like to thank Dr. Salama for inviting me. If there are any specific questions, one can email me. My email address is there as well, and I look forward to some questions on the Dental XP forum as well. And as a last quote to all this is that a lot of us believe that youth have that the substitute for knowledge is experience, because we don't have the experience under our belts like some of the more aged and veteran clinicians out there. But we have to understand too that that experience is not a substitute for knowledge either. And there's a lot coming out with these new materials, this new class of materials that solves a lot of the old problems that we've had with titanium. And if we're able to embrace these, then I think our patients will be served better, and I think that our outcomes are going to be much superior to what we've had in the past and what we've struggled with in the past. So again, I'd like to thank the Dental XP community, and hope to see everyone in Miami.